You're listening to the Pace Radio Network here at paceradio.net.
The views expressed by the individuals during this broadcast are their own opinions, and they may not be the same as those of their group or other organizations they may be involved with.
All medical advice during our broadcast is not a medical opinion and should be checked with your medical physician.
Look at all that money, yeah, the money that they spent. Take another look now and take some time for hemp. I know cut trees for paper, cause it hurts the environment. Stop deforestation, yeah, it's time for hemp. Oh, an acre of hemp makes 20 barrels of oil. No need for pesticides to poison all our soil. People got no food, they got no clothes, they got no rent. Well, right now it's time for hemp.
Thank you for taking time for hemp. I'm your host, Casper Leitch. On the program today, we are looking at medical cannabis as a wonderful plant for our everyday health care needs. And we've put together a interesting medical roundtable of experts to come together and to discuss the wonderful aspects of this amazing plant. My joint host, Al Byrne, and I will be discussing this plant and some of the amazing research that's been going on with Dr. Andrew Weil, who I think many of you know has done a handful of books and is an amazing speaker on all types of topics when it comes to these plants, not just cannabis plants, but all kinds of plants, and how wonderful Mother Nature has put together a pharmaceutical of beneficial plants for the human body to use. And we'll be discussing other aspects of the plant with Dr. Raphael Mechoulam from Israel. He is considered the father of marijuana research, a father of cannabis research. We also have Dr. Donald Abrams on the show today, and we've got Lynn Mathre on the program. And I do encourage you, if you're listening, to download this program if you get a chance and share it with your friends and other medical professionals who might benefit from hearing what our guests have to share. And let's get focused on the healthy body and the healthy mind that's created by using the medical marijuana plant in such a healthy way with our joint host, Al Byrne, and someone I am lucky enough to have met once and have always enjoyed his work, his writings, and anytime he's on TV, I make it a point to watch him, Dr. Andrew Weil. Dr. Andrew Weil, it's quite an honor to have you on my big broadcast.
Thank you.
Well, I agree with you, Casper, and I thank you very much, Andy, for coming on board. Dr. Weil is a very well-known, prolific author, many books, just a few of them here, From Chocolate to Morphine, The Natural Mind, Spontaneous Healing, Spontaneous Happiness. I'm going to say that Dr. Weil, I hope I use the right term here, Andy, but you are the founder of the University of Arizona's Center for Integrative Medicine.
That's correct.
And integrative medicine, I think that would be a way to start here. A lot of our listeners might not know what that means. Could tell us all.
Well, first of all, it's the way of the future. I think the short definition is that it's the intelligent combination of conventional and alternative medicine. But really, it's much more than that. It's a new system of medicine that focuses on the body's innate capacity for healing, that looks at patients as more than just physical bodies, that considers all aspects of lifestyle and understanding health and illness, that places great emphasis on the practitioner-patient relationship, and uses all available therapies to manage disease and promote health as long as they don't cause harm.
Why not more integrative medicine centers in more medical centers around the country?
Well, it's coming. There's a group called the Consortium of Academic Health Centers for Integrative Medicine, and more than a third of the nation's medical schools have joined that. There are many textbooks of integrative medicine. In many, there are courses in integrative medicine taught at many schools. We operate an integrated medicine clinic in Phoenix. We have a very robust research department. I mean, it is coming, and it's coming not just because of patient demand, but because of economic necessity. As you know, our healthcare system is in tatters, and it's going to get worse. And integrated medicine really offers the promise of reducing healthcare costs by shifting the emphasis to health promotion and prevention, and by bringing into the mainstream treatments that aren't dependent on expensive technology, including pharmaceutical drugs.
Well, that's quite a growth. I really didn't know. You must be very proud of that accomplishment, Doctor. I would be. We, of course, we've only got a few minutes here with you today, but how do we integrate cannabis into our medical system?
It's part of a larger problem that there is really no teaching on botanicals and natural products. That's something we're trying to remedy. In our training programs, we have a very strong curriculum in botanical medicine, and we include information on medical marijuana. So, we are trying to reach physicians and allied health professionals with that. That's gradually coming, but it's part of a long-standing neglect of this area in conventional medicine. There's something like 400,000 deaths a year just in the hospitalized patient population in this country directly due to adverse reactions to prescribed drugs. And these are not mistakes. These are the right drugs given to the right patients for the right conditions, and 400,000 people die each year. The deaths that are caused by botanicals are a handful and usually result from mislabeling of something. And yet the press, both the medical press and popular press, are filled with articles about the dangers of herbal medicine. The general message out there is that herbal medicine is dangerous because it's unregulated, whereas the products of pharmaceutical laboratories are safe, and it's just the other way around. Cannabis is probably one of the safest of all therapeutic agents. You can't establish a lethal dose for it. It has an enormous safety range that's unmatched by really anything that we use in pharmaceutical medicine.
One of the things that my personal physician made it a point to prescribe to me for one of my ailments was medical marijuana. He was in his 70s, and I was in Indiana, and he made it clear he could lose his license by doing so. Now, how does the medical community review medical marijuana now coast to coast? Are you still considered one of those on the fringe medical doctors who's reaching out for alternative ways to heal the body, or are they starting to recognize the many medicinal values in this plant and are starting to rally around it?
I think it's slow to come within the medical profession. I think this has been a patient-driven, consumer-driven movement. There's a need for much more education. Also, there's a problem in that from the point of view of medical doctors, medical cannabis use is not cleanly distinguished from recreational use, and that makes them uncomfortable. And I think for medical use, we need to have preparations that look like medical drugs. So, for example, this product that's sold in the UK and many other countries called Sativex, that's a whole cannabis extract that you spray under the tongue. And I've seen some products like this sold in dispensaries in Colorado, for example. This looks more like a medical preparation that doctors would be more comfortable using. Most doctors are not going to feel comfortable recommending that patients smoke something as a therapeutic agent.
Well, yeah, we can get on that, and of course, smoking is a sort of a red herring now. We have vaporization and topicals and edibles, sprays, and chewing gum. I mean, it's gone beyond the government's rhetoric, Doctor. But at the same time, we've also learned, especially in the last 4 or 5 years, about the CBD-rich cannabis. Which may mean that we could have a THC-depleted cannabis, which would be less active. That seems attractive.
Yeah, well, that's very interesting. I would say also that clearly our society is on a path toward totally revisioning the cannabis plant and embracing it. I think we are moving toward total acceptance of it. I think it will be eventually legalized everywhere, both for recreational use and medical use. I hope we will begin also producing hemp fiber. I mean, we let all that production slip away to China. For hemp food products, we let all that production slip away to Canada. You know, this is a plant that we should be embracing and cultivating for its many uses.
Well, you know, that's a key word. Every time I talk to the federal guys, they keep saying marijuana the drug. And I keep saying cannabis the plant. It's a plant. It's not a drug.
It's a plant. And it's a highly useful plant, probably one of the most useful of any plants. It's one that's been grown in many cultures for different purposes. And as I say, our cultural prejudice against it in recent times has really limited our ability to enjoy its benefits. And I think we're now seeing that change. So I'm quite confident that we're moving toward total acceptance of it and legalization of it.
What opened your eyes to this, Dr. Weil? I mean, so much propaganda against it. Being a physician, you actually probably put your license on the line by even opening your mouth about it way back when, you know, and you were very brave even 20 years ago to address it in your books.
Well, it's more than that. I, as a fourth-year medical student at Harvard Medical School in 1968, I did the first double-blind human experiments with marijuana. That was published in Science magazine. So I'd say it's almost 45 years that I've been writing and saying what I believe are truthful things about cannabis. So
what
I have
led
a
you
long
to that?
history of doing that.
What led you to that? What made you come to this plant first to begin to study it and then realize its value?
Well, I was studying ethnobotany at Harvard, which is the study of plants as used by native cultures and medicinal plants. And here was a plant that had tremendous uses in medicine of the past and also as a psychoactive plant. And I had tried it myself and found it very interesting. I knew many people were using it. This was in the mid-1960s. And it was just astonishing to me that so little was reliably known about it scientifically. So I wanted to study it and see what I could find out about it. We did, very simple psychomotor tests. You know, one of the things that we showed, there was a widespread belief back then that marijuana dilated your pupils. We showed that it didn't. There was a widespread belief that it made you hungry because it affected blood sugar. We showed that it had no effect on blood sugar. Very simple stuff, but it didn't. And I think most importantly, we showed that you could study marijuana in a laboratory in human beings and get away with it. And there had been no human research with it. So, that was a real precedent to show that this was something you could, in fact, study.
What's been the most surprising fact about this plant to you?
Well, I think the discovery of the endocannabinoid system, the fact that we have receptors for these analogous compounds throughout our body, that they seem very key in regulating appetite and pleasure and immune function and are part of our defenses against cancer, and the possibility that, manipulating the system, may offer many medical possibilities. I'd say the most exciting frontier is looking at the possibility that cannabinoids may help prevent and treat many forms of cancer.
And nutritionally, doctor?
Well, I think, cannabis is the source of an edible seed and an edible oil. That oil has a very healthy fatty acid profile. It's got, a fraction of omega-3 fatty acids that we need in our diets. The seed has a lot of fiber. You can make good foods out of hemp. I think hemp milk is very good. I much prefer it to rice milk. It's an alternative to soy milk. I think hemp seeds themselves are quite delicious if they're just dry toasted and flavored with something. So, these are good, nutritious foods.
I know we're getting close to, you've got to run off on us pretty quick here. I was wondering if you want to give out some information about your, maybe a URL or something about the center where people
Sure. My website is drweil.com. That's drweil.com. There's a wealth of information there about medical conditions, alternative treatments, integrative medicine, and there's a lot of information there about our clinic, our training programs, conferences, and so forth.
I want to thank you so much for being part of our big broadcast, and it has been quite an honor to have you on the show. I look forward to having you back on our program.
Great, I enjoyed it, and you're doing good work.
Okay, now moving right along, Al, our next guest is
a doctor from San Francisco, a medical doctor named Donald Abrams. He is the chief of hematology oncology at San Francisco General Hospital. He is also a professor of clinical medicine at the University of California in San Francisco. Dr. Abrams, are you there, sir?
Yes, I am. Good morning, Al.
Good morning, Donald. Very nice to hear your voice. We want to get right to business here. The folks that are listening across the country and around the world are interested in real science. And I know that your science has been frustrated by the United States government. I wonder if you could tell the folks about trying to do a positive cannabis study in the United States, the difficulties.
Thanks, Al. So the only legal source of cannabis to study in human research is the National Institute on Drug Abuse, NIDA. And NIDA actually has a congressional mandate to only study substances of abuse as substances of abuse. So when I started way back in 1992 petitioning NIDA for cannabis to do research in patients with HIV and the wasting syndrome, I quickly or not so quickly learned this and realized that my request for cannabis and for funds to fund the research from NIDA could never be granted. Since that time, however, NIDA has made cannabis available for studies to look at its medical benefits as long as they're not funding it. That's okay with their congressional mandate because they're not funding the studies, but being the only legal source of cannabis in the country to study, if somebody does want to look at, for example, the effectiveness of cannabis in treating a pain syndrome, if they can get funded elsewhere, NIDA does make their cannabis available. So in truth, the situation has changed quite a bit, such that, for example, now we're hopefully going to be funded to do a study of cannabis in sickle cell patients. The funding comes from another branch of the government. Currently it's sequestered. Hopefully it will soon be released. And we're working with NIDA to obtain the cannabis, and they're very helpful. In fact, in this particular study, we're interested in looking at a blend of cannabis that has both THC, tetrahydrocannabinol, the main psychoactive ingredient, and CBD, or cannabidiol, which is an anti-inflammatory analgesic cannabinoid that's not present in all strains of cannabis. So NIDA is actually being very helpful in the current situation. But the real truth is that there is a congressional mandate, and there, in this country where we're fighting a war on drugs, it's difficult to study substances which are scheduled as Schedule 1, meaning high potential for abuse and no accepted medical use. It's difficult to study Schedule 1 substances for their medical benefit.
Well, let me shift you to another subject that I know you're very familiar with and people need to know about, is the use of cannabis with cancer. Could you expound on that a little bit?
Yeah, it's when I was training to be a cancer specialist, I hate to date myself, but it was in the 1970s. And in the 1970s, that was a whole different time in the world of cannabis. Jimmy Carter was president. There was much more widespread use of cannabis amongst the American public. And in my training to be a cancer specialist, even in 1970s, there were a few cancers that we could cure. And interestingly, they were cancers that mainly affected young people, Hodgkin's disease, testicular cancer, and also, interestingly, the chemotherapy regimens that we used then are pretty much what we use now. And they're very potent and very effective, but they also cause a lot of nausea. And back in the 70s, we really didn't have very effective anti-nausea medications like we do now for chemotherapy. And so many patients, young people with these cancers that we could cure with aggressive chemotherapy, said, you know what, your prescription anti-emetics or anti-nausea drugs are okay, but smoking cannabis works much better. And so that was the first clue that, cannabis had some potential for chemotherapy-induced nausea and vomiting. And, again, it really has not been studied, the whole plant, but dronabinol, which is the synthetic version of delta-9 THC, was ultimately licensed and approved as a treatment for nausea and vomiting back in 1986. Dronabinol, again, is just one chemical in the plant. The plant has 400 other chemicals, 70 other cannabinoids like THC, and also other chemicals in the plant that have medical benefits. So as a cancer doctor now for the last 30 years, growing up in the 70s, just a day doesn't go by when I don't see a cancer patient who has nausea, vomiting, loss of appetite, pain, depression, and insomnia. And most of my oncology colleagues will then take out their prescription pad and start writing prescriptions for 5 or 6 different medications, all of which may interact with each other or with the chemotherapy that the patient is taking. And I can just recommend, because I'm fortunate to live in California, that patients try cannabis, because cannabis is one medicine that can speak to all of those different symptoms. And it's also a medicine that many of my patients can grow themselves. And if you have cancer and part of you is dying, or you feel that you're dying, the ability to bring life out of the ground is something that's very rewarding. And if you're growing your own medicine, that's very empowering. So I see patients every day, as I say, for whom I recommend cannabis, and who tell me that cannabis, for example, was the only thing that decreased their nausea and vomiting, despite all of the modern anti-nausea drugs that we have to go along with chemotherapy. The only thing that allowed them to play with their kids. On the other hand, I see patients who are near death, who are put on high doses of opiates and get totally zonked and can't communicate with their family anymore. And they find that if they wean down from their opiates and use cannabis instead, that their pain is relatively well controlled, and they are much more capable of being in the moment and sharing the last weeks, days, months of their life with their family and loved ones. So I think it's a very potent medicine, and I often find myself opposing on a panel or a debate people that are in the drug abuse community. And I always say it's sort of like the blind men and the elephant, if people remember that analogy. I mean, I'm a cancer doctor. I'm not seeing the small percentage of patients who have cannabis dependency problems that my colleagues in substance abuse see. So where they see it as this horrible, agent, for me, it's a lifesaver for many patients.
Doctor, could you just go over a little bit more about how cannabis can supplant or replace other medicines? And please define synthetic cannabis. I've been told that people think it's some sort of real whole plant synthesis, and it's really a petroleum-based product, is it not?
Pharmaceutical companies can synthesize molecules, and delta-9 THC is a 21 carbon. I believe that they are synthesizing the delta-9 THC and putting it in sesame oil as a medicine. But, there are other cannabis medicines as well that are out there and available. Sativex is a under-the-tongue spray, which is an extract of the whole plant, which is available in Canada and many European countries for treatment of spasm, for example, from multiple sclerosis. But in answer to your question, yes, again, as I said, my patients have nausea and vomiting, weight loss. So nausea and vomiting, we have a lot of antiemetics. But again, for some patients, even the most powerful of the anti-nausea drugs that we give with chemotherapy don't work for them, and they do report that cannabis does. I believe Melissa Etheridge came out nationally and said she could not have completed her chemotherapy for her breast cancer if it had not been for the beneficial effects of cannabis. There aren't too many medications that we have that increase appetite, and in fact, none of the prescription anti-nausea medicines we have increase appetite. Cannabis increases appetite. So here you have something that decreases nausea and increases appetite. So you could perhaps decrease some of the anti-nausea prescriptions, which in and of themselves have some side effects. Many patients get constipated. Again, as I said, we don't have many prescription medications to increase appetite. One that we do prescribe a lot actually increases appetite and weight, but it's mainly water weight and not lean body mass. I've done a number of protocols in patients, both pain from nerve damage as well as pain on chronic opiates. And what we found in our chronic opiate study, which was really a pharmacokinetic interaction study to see what happens to the blood levels of morphine or oxycodone when patients inhale vaporized cannabis along with their opiates. And we found that there was no real change in the level of the opiates in the bloodstream, but what we did see was that patients achieved some greater relief of their pain when the cannabis was added to the chronic long-acting opiates. So this would suggest that people could perhaps lower the dose of their morphine or oxycodone and be able to stay on a lower dose for a longer time when it's given in addition to cannabis. Sleep. Many patients have difficulty sleeping with cancer or without cancer. There are different blends of cannabis. The cannabis sativa seems to be more stimulating, where cannabis indica seems to be more sedating. High THC variants of the medicine seem to be also a little more stimulating, where high CBD or cannabidiol-containing strains are more sedating. I have patients who swear by high CBD cannabis to help them sleep. And many of the short-acting benzodiazepines that physicians prescribe for sleep are really quite habituating and addictive and associated with a lot more side effects than cannabis. This is a very safe medicine, despite what the government tells us in their drug war propaganda. So, again, decreasing sleep medicines and depression. I mean, it's all going to come down, as everything else does, to our genes and the field of pharmacogenomics, how different people respond to different medicine based on their genes. And we now know that we all probably have different cannabinoid receptors that may be slightly different by one amino acid or another to other people, which might make them act differently. So some people, when they're exposed to cannabis, feel nothing. Some people get very elated, and some people might get paranoid and a little depressed. But for those people who get some elation or euphoria, which we consider to be a negative thing, I mean, if you're dealing with a terminal patient, I don't think euphoria is an adverse experience. I think it's a good side effect. And I think cannabis is more useful than some of the antidepressants, which my patients tell me just basically numb their feelings and make them no longer care about anything. So, I mean, we can replace a lot of prescription medications with cannabis if the patient is having a good responses.
Well, Dr. Donald Abrams, I want to thank you so much, sir, for joining us today. Your information is priceless, and I look forward to working with you in the future, sir. Thank you again.
Thanks a lot, Al. Pleasure to talk to you.
You're listening to the Pace Radio Network here at paceradio.net.
You are listening to the Time for Hemp Global Broadcasting Network. Please share us with your friends.
My next guest on this program, this really a historic program, is Dr. Raphael Mechoulam. I have nicknamed Dr. Mechoulam the grandfather of medical cannabis, but indeed he is. Back in 1964, it was Dr. Mechoulam and his colleagues that isolated THC in the cannabis plant, and that has led to the astonishing science over the last 50 years that has led us to a discussion that we just had with Dr. Abrams and a discussion we're about to have with Dr. Mechoulam about the endocannabinoid system. Dr. Mechoulam, welcome, sir.
You're welcome. Can you hear me?
Oh, yes, sir. Very clearly. Very clearly. I would like you, please, to tell the folks a little about your background and your lab and explain to the people the significance of the endocannabinoid system, doctor, if you would.
Well, I'm a professor of chemistry, medicinal chemistry. I was a very young man when I looked at projects which were of interest, and I was surprised to a large extent to see that while morphine had been isolated from opium, early 19th century, and cocaine was known again 100 years previously. The active constituent of marijuana, of hashish, had never been isolated, had never been identified, really. That seems strange. So I got some hashish from the police through the Ministry of Health here, and we looked at that, and we were able to isolate and elucidate the structure of the active constituent. We didn't know which one of them is the active constituent, so we had all the compounds tested on monkeys, and we isolated about 10 compounds, the major ones that are present in cannabis, and we found that only one of them, the THC, caused what we would probably say it's the same thing that happens in humans, happens in monkeys, and that was the only psychoactive compound. So that was 1964, and we also identified cannabidiol, which had no psychoactivity but had caused all kinds of other effects. And for the next 10, 15 years, 20 years, people looked at THC, looked at cannabidiol, looked at what happens in the body, looked at what these compounds do. But surprisingly, it was not known how they do that. Then my group and additional groups started looking for some details. And yes, we thought that there should be a specific biological thing, whether it's an enzyme, whether it's some receptive site or something in the body that THC stimulates. And indeed, Aline Howlett, she was a very young researcher at that time. Aline Howlett and her group found that there is a receptor in the brain. Then a second group in the UK found that there is a second receptor. They were different. And so we then knew that THC acts on a receptor and does whatever it does through a biological entity. Now, these receptors are not found in the brain because there is a plant out there. It doesn't work that way. There should be compounds which we produce, our brain produces, and these activate those receptors. So we started looking for the compounds, our own compounds, the endogenous compounds, which will activate these receptors. And about 15, 20 years ago, we were able to identify very small amounts produced by the brain of two compounds. One, the first one we called anandamide. Ananda is, we were very happy to have it. Ananda in Sanskrit is joy, happiness. We thought that it may be involved, but maybe we called it that because we were happy to complete that research after so many years. And my colleagues and I called it indeed anandamide. Then a second compound, which has a very long name, but the short name is 2-AG. These two compounds are formed in our body, both in the brain and in the periphery. They activate these receptors, and THC actually mimics their action. There has been a huge amount of work on these two compounds, on the whole endocannabinoid system, if you wish. These are the receptors, and these are the compounds found in the body that activate them. There are the mechanisms that the body uses to amplify or to block these actions. And all this represents the endocannabinoid system.
But if you could just tell the folks listening, we've gotten to the endocannabinoid system. What does this mean for them?
Well, we know, and we had studied the activities of THC and of cannabidiol previously quite extensively. And we realize that they, as I said, they mimic the activity of these endogenous cannabinoids. Unfortunately, we always believe that the medicine goes ahead. Well, fast, and we are much better than, let's say, in the 20s. Well, this is not exactly true. When insulin was discovered in the early 20s, within 6 months, it was used as a drug. When the steroids, the corticosteroids, were discovered in the late 30s, early 40s, within a year or two, they were used as anti-inflammatory agents and then as many, many other types of drugs. Well, anandamide and 2-AG, although they are present in the brain, they're present in our body, they do a lot of things, and they have never been administered to a human, at least not legally. Why? Because in order to put a compound like that in the body, one has to look at the toxicity. Well, these compounds are not toxic, but in order to do a very wide-range toxicity, one needs a lot of money, and nobody has spent that kind of money. So we do not know what anandamide and 2-AG do when we introduce them into the body. We can give THC under certain conditions, and we have done that many times. We have used anandamide and 2-AG to look at diseases of mice and rats and other animals, but we have never given anandamide to a human. We have given THC. As a matter of fact, we gave THC about 25 years ago, or maybe it was 20 years ago, to a group of children who were undergoing cancer chemotherapy. And we gave THC under the tongue, 5 milligrams pure THC, prepared in my lab, and all these children stopped vomiting. We published that. We gave it 400 times, and 400 times the effect was absolute, 100 times absolute. We gave the other compound, cannabidiol, to patients that had epilepsy. This was done with colleagues in South America. And yes, we had absolute activity in these very difficult epilepsy patients. This has gone on and on. Very recently, a group in Germany did a very, very exciting work with cannabidiol, very large doses of cannabidiol, about 800 milligrams a day. They gave it to schizophrenia patients, and they compared these patients with patients that were getting one of the standard antipsychotic drugs. Now, both groups, in both groups, one could see positive effects, and both groups were essentially the same. The compounds worked. Both cannabidiol worked, and the known antipsychotic drug worked. But, and that was a big difference, cannabidiol did not cause any side effects. The antipsychotic drug, which is widely used, is known to cause side effects, and it did cause side effects. So here we have anti-schizophrenic drug. Hopefully it will be used, but I doubt it because there is no patent. No company will try to put it on the market. Here we have a compound at high doses, very high doses, that works in schizophrenia. Probably the same is true for anxiety. Now, I wish we could test anandamide and 2-AG in patients. We have done, and we and many, many others have done a lot of work on mice and a lot of other animals in a variety of diseases. And here we have a very promising drug which has never been evaluated. But let me go into a little bit deeper. The receptors, there are two receptors, the endocannabinoid receptors. One is called the CB1 and the other is the CB2. Stimulation of the CB1 receptor causes the high. It also causes a lot of positive effects, but it causes the high, and therefore probably most pharmaceutical companies will not be interested in the CB1 receptor. By contrast, the CB2 receptor does a huge number of very positive things, and it does not cause the psychoactivity, which the pharmaceutical companies would very much like. So there are a lot of compounds that are being prepared today that act specifically on the CB2 receptor, and it acts on a huge number of diseases, at least in animals. Now, these compounds act on so many diseases, it becomes a little bit strange. How come that stimulation of one receptor will cause so many things? Well, it is quite possible that it is a general protective agent, a general protective system, and it acts on basically on inflammation. When one stimulates the CB2 receptor, one gets an anti-inflammatory effect. And one can see that in heart diseases, ischemia of the heart. One sees that in stroke. One can see that in inflammatory bowel diseases, in Crohn's disease, a lot of diseases that are based on inflammation. We have done, in collaboration with Spanish colleagues, work on Alzheimer. We found that if we cause an Alzheimer-type disease in mice, we can lower the effects by administering cannabidiol. Other groups in other animal models have shown that again and again. So here we have a type of compound that may act on a huge number of diseases.
Could you tell us, Doctor, first of all, I should identify for the folks listening that Dr. Mechoulam is the Lionel Jacobson Professor of Medical Chemistry at Hebrew University in Jerusalem. And he also runs an incredible research lab. Doctor, what is your lab working on right now? What are your more goals that you're looking for to accomplishing?
Well, you see, anandamide and 2,8-G are two important compounds, but our brain, for some strange reasons of which we're not fully aware today, makes about 200 to 300 related compounds. We know very little about their activity. We're looking into the activity of some of these compounds, which are related to the cannabinoid system. They may not directly activate these receptors, but they're somehow related because we can block their activity by blocking the endocannabinoid system. So they're related somehow. And let me give you one example. Nothing that has to do with the brain, but actually has to do with osteoporosis, our bones. There are statistics showing that in the Middle East, around the Mediterranean, there is 50% less osteoporosis in women than in Northern Europe. And possibly that was due to olive oil. So we looked at olive oil, we looked at the constituents, nothing major. Then we decided maybe the body converts that constituent of olive oil or lactic acid, converts it into something which is closely related to anandamide, the endogenous cannabinoid. So we looked for that kind of compound in bones, and lo and behold, we found that. We found a compound which is closely related to anandamide, to the endocannabinoid system, and which is a very potent anti-osteoporotic compound. We synthesized it, and we tested that in animals that we caused in them osteoporosis, and it is extremely potent. Now, this compound, oleucirine, I hope that somebody will develop it. Now, this same compound is present in the brain. We haven't got a focused idea what it does in the brain. There are other compounds. There is another closely related compound which is present in the brain. When we identified it, synthesized it, we gave it to animals, and it causes, it affects their blood vessels. It opens them up. And so we started looking at that. And we found that this particular compound, when given to animals after brain damage, after trauma, lowers the effects of the trauma. So here we have something, I believe, very promising. And there are about 200 to 300 compounds there waiting to be investigated. Quite a few other groups are looking into those compounds. Chances are that these compounds, many of them represent the natural, or one of the natural ways of fighting disease. Or if we go even further, maybe these 200-300 compounds also determine many of determine our behavior as human beings. If I can speculate for a second, we are all different. Each one of us has a different personality. We haven't got the foggiest idea why each one of us has a different personality. Is it possible, just possible, a speculation, that it has to do with the equilibrium of these 200-300 compounds, which may cause these differences? So we are going into psychology. We published that in a psychology journal, and we said it's a speculation. And the editor said, no, it's fine. It makes some sense. So chances are the endocannabinoid system is not just something that our body has to fight disease, which is extremely important, of course, but it also has to many other effects, or it influences our behavior. I hope that in the next 50 years, people will find out a little bit more.
Well, Doctor, thank you so much for joining us today. It was a remarkable lecture you just gave. My best to you, sir. I hope we meet again soon.
Bye-bye.
You are listening to the Time for Hemp Global Broadcasting Network. Please share us with your friends.
You're listening to the Pace Radio Network here at paceradio.net.
My next guest is from Europe, from Germany in particular. Dr. Grotenherman is a medical doctor, and what I would like him to tell us about is, of course, his personal experiences with cannabis medically and his founding of the IACM. Dr. Good day, sir.
Hi, Al. Good to talk to you.
Thank you for being here with us. If you could jump right in, I know you've listened to Dr. Mechoulam. If you could jump right in on your ICAM and focus, if you can, on the CBD system and the ECS system and what your European colleagues are thinking about this science, I'd appreciate it, sir.
Okay, very good. Well, I started to get involved in the issue of cannabis and cannabinoids as medicine about 20 years ago. And I noticed that in Europe there is no much knowledge on this issue. And with some friends I decided to form a group, the German Association for Cannabis as Medicine. This was in 1997. And North America and Canada were much ahead of Europe concerning this issue. And then some friends from outside Germany, for example, from the UK, Roger Pertwee, or from Spain, and they asked, why don't we make this organization, the Association for Cannabis as Medicine, international? And we decided to form a scientific group, an international group, which is the ICM, which was formerly called International Association for Cannabis as Medicine, which was founded in 2000. The main thing was that most people were working very locally or nationally, and we found it very important to have an international exchange, not only on the scientific level, but also on the political level, and to bring people together. And so we formed this group, and the main reasons were to promote exchange of information between researchers, healthcare practitioners, patients, and the public, and to disseminate reliable information on the pharmacology, toxicology, and therapeutic potential of cannabis and cannabinoids. So this was the start and main reason for forming the IACM. And it's still very important. Many people are thinking on this issue on a national basis, but we need a global view on it. What is happening in Europe? What is happening in North America? What is happening in Latin America? What is happening in Africa? And we try to work together and exchange information.
Are you trying to become the global umbrella, Franjo? I mean, I think your group would be well suited to do that. Is that one of the goals of your group?
I'm also very active nationally in Germany as the head of the German Association for Cannabis Medicine. But I was also always interested in having a broader view to other countries, what is happening there, and to bring scientists together. For example, we have meetings every 2 years, and well, this is one of my main focuses, to bring people together and to spread the information. For example, our ISM bulletin is available in 6 languages, so not only in German or not only in English, but in Spanish and Italian and other languages. And information, reliable information, is very important to get people involved, to get people think about it. What is the value of cannabis? What is the function of the endocannabinoid system? Because the politics is also always influenced by prejudices and not always by knowledge. And this is what we want to try to change, to bring the knowledge, to allow people to get the knowledge and to get reliable knowledge on the issue.
We here in the United States know very little about what is going on with cannabis research in Europe. Could you give us a lowdown on Germany in particular, and then your best speculations about some of these other countries that may be leading the way here that we don't hear much about?
Well, I can give you some examples. For example, today there is no major university in Europe where there is not scientific research on the endocannabinoid system or cannabis or cannabinoids. It's mostly basic research. For example, in Spain, there is Dr. Manuel Guzman, who is the leader of cannabis and cancer. Not the side effects of cancer chemotherapy, but how THC and cannabinoids can cure cancer, perhaps. And we have, for example, the group of Roger Pertwee in the UK is also a very leading group in endocannabinoid research. And we have also some groups in Germany who are, for example, at the Max Planck Institute, who researched on the endocannabinoid system and anxiety or post-traumatic stress disorder. So we have in Europe many centers which are leading in some of these special issues. And of course, there's always an international cooperation on these issues. As, for example, as Raphael Mechoulam told us, to elucidate the function of the endocannabinoid system, it's always an international process. And so there are groups from Spain, UK, Germany, Israel, USA, Canada, working together on these issues.
How about your university system? Is specifically your doctors, your medical schools in Europe, the nursing schools in Europe, are the doctors and nurses now taught about therapeutic clinical uses of cannabis? Are they taught about the endocannabinoid system?
The knowledge is today quite limited. The situation for patients is very different in different European countries. For example, the Netherlands or Spain have a situation where it is very easy for patients to get contact or to get cannabis to treat their symptoms. Whereas, for example, in Greece or in France or in Sweden, it's very, very difficult. People may get an exemption to get Marinol, and they will never get an exemption to get cannabis. So this is very different in different countries. And similarly is the situation for the knowledge of the doctors. Germany is somewhat in between. Last year we managed to publish I, together with Kirsten Müller-Weil from the University of Hanover, to publish an article in the German Medical Association journal on the medical use of cannabis and cannabinoids, and we had to work for 10 years to publish it and to bring it to every doctor. But many doctors are still very reluctant. And for example, in Germany, we have the situation that doctors can prescribe dronabinol, they can prescribe Sativex, they can prescribe Nabilone, but there are only about 4,000 or 5,000 patients in whole Germany who get access to these medications because they have to pay it on their own and they are rather expensive. And a few years ago, the government agreed, okay, we make up a program to allow patients some access to cannabis and to get an exemption for the use of cannabis if no other medication works. And currently there are only about 200 patients in this program. And the main problem for the patients is to find a doctor who says, yes, this patient needs cannabis because all other medications do not work. And I am ill for about 23 years and lying in bed, and I do not practice for a long time. But 1 year ago, I decided, well, I will open a medical practice so that people can come to me and who don't find doctors. And I get patients from all around Germany because it's very difficult for many of them to find a local doctor who supports them. And the situation is much easier in Spain, for example, or in the Netherlands, and much more difficult in Greece or Bulgaria or Norway or France, where it's even more complex and more difficult.
Yeah, it sounds sort of like in the United States, where you go to some state over here, Franjo, like California or New Mexico, they have a very good program in effect, and they'll treat all sorts of symptoms. In fact, in California, there's no list or limit. But you go to another state like, these Confederate states, all these old Confederate states in the Southeast, and they got their heels dug in, and they're not going to let their people have cannabis to help them no matter what. It's a strange, baffling situation to hear that it's the same in Germany. Before we let you go, Doctor, I'd like to call the audience to get to the attention of two great books, both by Dr. Groton Herman and a co-author, Dr. Ethan Russo, a U.S. author. But they are the Handbook of Cannabis Therapeutics from Bench to Bedside, and Cannabis and Cannabinoids, Pharmacology, Toxicology, and its Therapeutic Potential. You can find them on Amazon, guys. Doctor, thank you very much, sir, for being with us today. We much appreciate it.
Well, nice to meet you.
You are listening to the Time for Hemp Global Broadcasting Network. Please share us with your friends.
You're listening to the Pace Radio Network here at paceradio.net.
Our next guest comes to us from the United States, again, California. We're going to find a lot of doctors out there have been using cannabis with their patients as a medicine for a long time. And one of them is our next guest, a medical doctor named Dr. Jeffrey Hergenrather from, Sebastopol you're in, Jeff?
Yes, that's right. Sebastopol, California, up in Sonoma County.
Well, good morning, and nice to hear your voice again. I think what I'd like you to concentrate on, at least at the beginning, we've talked to Dr. Mechoulam. I know you've heard him and Franjo about the science and the research, etc. How about telling us about you as a clinician? How is that all going, and how does clinical work in California go now? Is it getting easier? Is it getting smarter, or what's going on?
Well, it's going both ways, really. But just first of all, thanks so much for the invitation, and I'm really honored to be with such a esteemed group of scientists and physicians, getting an opportunity to tell my story. I've been in the practice of cannabinoid medicine in Sebastopol with opening an office in 1999, but since we passed the law to allow medical use of cannabis in 1996, I've been making recommendations. I've actually been recommending cannabis to patients since the 70s when I became a physician, because I did appreciate that there were therapeutic uses. But it's come a long way since then after opening an office and really learning from the patients what conditions cannabis was working for. In order to really develop my scientific basis around my practice, I did join Dr. Todd Micarea in the Society of Cannabis Clinicians back in 2000, and along with Fred Gardner, who produces the journal O'Shaughnessy's, to put out information on a regular basis to people, both physicians and patients, in explaining so much about both the science and really the politics of cannabis medicine. And in answering your question, California has a unique law in that we can allow use of cannabis for any condition for which cannabis provides relief. And that opens the door widely. And really, based on our understanding of where these receptors are in the body, it makes perfect sense that it helps with such a wide number of conditions. So I also joined the IACM and Franjo's group in Germany and have been a regular member of the IACM. I've been a member of the ICRS, the International Cannabinoid Research Society, which meets annually between Europe and North America. So going to these conferences has given me a really broad scientific basis and understanding of the science of cannabis and why it works the way it does. Now, in my practice, I really designed the practice to grow slowly because I wasn't really into what I was seeing as these real quick evaluations where you hardly needed more than, be able to fog a mirror to get a recommendation. I just wanted to be able to spend enough time with the patient to really understand their condition, represent them in court if I needed to do that. I usually spend about an hour to an hour and a half with the patient on the initial visit and then see them on a regular basis after that. So I feel very comfortable in my own practice now with about 2,000 patients, probably at least half of them I continue to see on a regular basis.
This is a pet peeve of mine, but this is a special show, and I want to bring up one of my pet peeves. I'm hearing that you, a medical doctor, are having your medical judgment questioned by attorneys and cops. Am I correct?
That is correct. Law enforcement is really trying to get in between the patients and the physicians and determine what they can use it for and how much they can use. These are not issues that should be determined by law enforcement, obviously.
Well, I agree. That's why I brought the question up, Jeff.
Thank you. I wanted to tell you a little about the kinds of patients that I'm seeing in my practice. They range from those who have never used cannabis to those who are very experienced using cannabis. They range from infants to very old people. And I don't think there should be any limitation on the age that people are allowed to use cannabis for medical problems. I have an exciting case with a 1-year-old who presented with his parents with a large brain tumor, and due to a set of circumstances, they decided to try using cannabis oil rather than operate or irradiate or use chemotherapy. And over the course of several months, we saw this large, really inoperable brain tumor shrink, and now after about a year and a half, disappear. So to put limitations on the age of patients is just way off the mark. This should be determined by the physician. And then I see a huge range, Al, in the kinds of conditions for which patients present for the use of cannabis. And this is obviously based on the widespread pharmacological effects of cannabinoids. Some has been said about the analgesic properties. That's probably the largest single group of conditions, but it's a very potent antispasmodic. It helps with spasms of all kinds, whether it's from stroke or paraplegia, quadriplegia, or whatever the cause. Cannabis stops spasms just in a few moments. It has a potent effect in increasing appetite and stopping nausea. It has many anti-cancer properties. It's antibacterial, antifungal, and antiparasitic. Some has been spoken about the potent anti-inflammatory potential of it, and it works in many inflammatory conditions. It suppresses the immune system, so it's wonderful in autoimmune diseases. It seems to be really helpful for graft versus host, so people that have had kidney transplants or other organ transplants do better when they're using cannabis because it quiets the immune system down. Neuroprotection is a significant role, and people with MS and other degenerative diseases, dementias, seem to have a much slower progression of their disease, if not no progression at all. There are numerous dermatologic advantages in using cannabis for psoriasis and eczema and other lesions that I'll mention in a little bit. It helps the bowel, as Dr. Mechoulam mentioned, in Crohn's disease. It dilates the bronchial tubes, so it helps actually with asthma. It has great qualities in reducing eye pressure for glaucoma. It's anti-diabetic. It helps stimulate bone growth. It has numerous psychological benefits, reducing anxiety, helping with depression, and as was mentioned too, with cannabidiol especially, as antipsychotic. And it's anti-ischemic. It helps protect for heart disease, and it's also an anticonvulsant. So you get the idea that there's this huge range of conditions that really should be treated with cannabis. And in California, we do have that opportunity to use it for all of those various conditions.
Yeah, well, that's good. You know, I was listening to your list there, and I was, after a while, I got thinking of the list that Dr. Mechoulam made up many, many years ago. And your list echoes his after all those years.
Well, yes, it certainly does. And his list echoed the clinicians from the 30s and prior, when cannabis was used before it was outlawed in this country.
Give us a little on the American Academy of Cannabinoid Medicine, if you would.
The American Association for Cannabinoid Medicine, as well as the Society of Cannabis Clinicians, are organizations that are really one and the same group. We're physicians largely in California, but we're extending out to physicians across the country. Physicians can join in and give us their case reports to help us understand more about the conditions that are successfully treated with cannabis, which really brings me to the patients themselves and what I like patients to know when we see them. Really starts with some understanding of the receptor science, and some has been mentioned already about this, but I thought a little more would be helpful. And that is to say that these receptors that we speak of, the cannabinoid receptors in the human body and really throughout the animal kingdom, are based in the nervous system and the immune system. That's where they're housed. And when they're activated by these plant cannabinoids, the THC, the CBD, and the other molecules, they have this wonderful effect of bringing the body back to a home base. When we speak of homeostasis in medicine, we speak of the ability of the body to correct its getting out of line, too anxious, too cold, too whatever. The body has an ability to correct itself. And this is based on the endocannabinoid system. When we activate these receptors, it's like the reset button. It's like restore to factory settings button on a computer. It just brings us back home, helps us to relax. It was Dr. Vincenzo Di Marzo, our colleague in Italy, who said that cannabis and cannabinoids help us to eat, sleep, relax. And the protection one is about protecting from cancer cells, but also this neuroprotective quality. Forgetting is about the mind's ability to rapidly get rid of unnecessary information that the body is taking in. So there is an important role in forgetting and relearning that is mediated by the endocannabinoid system. I also like people to really have some understanding about risks and benefits of cannabis use. And, briefly, I would just say that the single most significant issue is bronchitis from chronic smoking. We do know from Dr. Tashkin's work at UCLA that it does not cause COPD, emphysema, or cancers of the lungs. Even the heavy smokers do not show any increased incidence of cancer, and in fact really have a reduced risk of developing cancer. So that's something that I like people to understand, although if they are smoking, I often will encourage their use of vaporization or other forms of cannabis because it can be a cleaner way to go and less irritating to the airway. Cannabis, of course, has a habit-forming quality, but it is not addictive. And the NIDA would have us believe that 9 or 10% of anybody who smokes cannabis is going to get addicted, as if this is a big problem. And it's really a silly and misleading designation. So I like people to really understand that, yes, they may use it. It really depends on the condition they have as to how much they use. Some patients are going to use it once a month, and others are going to use it every other hour, depending on the nature of their condition. Any withdrawal syndrome about cannabis use is really quite minimal. A big deal is made of it by NIDA, but it really is a pretty much insignificant problem for everybody that uses cannabis. There's no significant induction of schizophrenia. In Great Britain, when there was an 18-fold increase in the use of cannabis in the youth of that country between the mid-90s and the mid-2000s, there was no increase in psychosis or schizophrenia in that country. I also like people to understand that not all strains of cannabis are the same, and Dr. Abrams has pointed out that there is a difference in the sativa-dominant and the indica-dominant strains. And there's a difference, too, in the cannabidiol-rich strains if you want to achieve the medical benefits really without or with very little psychoactivity. So those are some of the things that I particularly like patients to understand on our first visit.
Doctor, you've had 2,000 patients, give or take a few. All of them have used cannabis. What kind of negatives have you seen, if any? Besides the minor things you just talked about, et cetera.
I would say over the years there have been 2 or 3 people that have just said it didn't really work for them. They tried it for whatever reason, they didn't like it. There's a rare person who just really can't tolerate any psychoactive changes. But by and large, people learn a way to use cannabis to mitigate symptoms of their diseases. And it's just been really a wonderful change in my medical practice to specialize in cannabinoid medicine for the tremendous benefit that is realized by patients. And really in California, there are millions of people who are benefiting on a daily basis with the use of cannabis. I think some of the biggest surprises for me in my practice have been seeing the skin conditions and the cancers that have benefited with cannabis use, where we have no other decent explanation for why the tumors have gone away. I've had patients with children with neuroblastoma, adults with melanoma, babies and adults with gliomas and glioblastoma brain tumors, patients with hepatic carcinoma, where these tumors have really melted away with the use of cannabis. They've disappeared with the use of cannabis. These are anecdotes, and we really want to study them in a way that would give much more useful meaning, because I have to say that this, people want to know, is this the magic bullet that we're looking for in cancer treatments? And it is and it isn't. And in some cases, it really works dramatically to help cancers disappear, and in other cases, it doesn't. And so I want people to understand that when they're going to use cannabis for cancers, that they may or may not find that it really is going to help with reducing the amount of cancer that they've got. It certainly is going to help with appetite and their mood and sleeping and, weight gain and nausea and vomiting and all the other symptoms. But whether or not it'll cause their tumor to disappear or not, some do and some don't.
Worth a try, though, wouldn't you say?
It's worth a try. And as Dr. Abrams said, when patients can grow this in their yard and have this relationship with a living plant, it means so much to them, and it's really worth a try, especially compared to some of the alternatives, which are going to make you sick, if not kill you, in an effort to try to control a cancer. In so many cases, we know that it won't kill the cancer to use conventional chemotherapy. It'll just give you a little more time. But in cannabis, even in some of the most difficult to treat cancers, we do see that people live longer and feel better. So it is worth a try.
Dr. Hergenrather, thank you so much for your time and your knowledge, sir. We appreciate it as always.
Thank you, Al. It's really nice to participate, and I appreciate the opportunity.
You are listening to the Time for Hemp Global Broadcasting Network.
You're listening to the Pace Radio Network here at paceradio.net.
The next guest is Dr. Denis Petro, medical doctor. He is a neurologist with some 30 years experience in adult neurology and pharmaceutical research as well. That research has been done with industry, with regulatory bodies, and he has great expertise in drug safety. He's worked all over the place, U.S., Canada, the United Kingdom, and right now he's talking to us from Eastern Pennsylvania. Hello, Dr. Petro. You out there, sir?
Hello, this is Petro.
Please let us know your background, let the folks about your background, and if you could go back in time and talk about your early clinical findings, especially with MS, and we'll go on from there if you could.
Sure. I actually go back to another era in time, and that is the 1960s. So when I started in medical school at Baylor University in Houston, Texas, in an MD PhD program, I was involved in measuring cardiac output in patients at several of the Houston institutions, including the Texas Institute for Rehabilitation and the Houston VA. And in measuring cardiac output, I was astounded to see that actually a range of patients were using marijuana clinically. Actually, my first patient was a very spastic teenage boy at the Texas Institute for Rehabilitation whose mother would bring in these cookies containing cannabis, and that was the only way I could get good cardiac output measurements after she gave her son some marijuana. And this is actually the same hospital where Gabby Gifford got her rehab after her brain injury. But this experience was reinforced in the 70s when I saw a number of patients, one patient especially who had leukemia and was using cannabis to take chemotherapy, and she became the first recognized adult with acute myelomonocytic leukemia to ever have a successful remission from her leukemia. Another case was a young, late 20s vintage MS patient who actually smoked marijuana in the clinic, and his spasticity literally melted away. So I applied to the FDA to do a clinical trial, and after about 4 years of back and forth, was able to do the first American double-blind placebo-controlled trial that demonstrated that cannabis was an effective therapy for muscle spasms in MS patients. And obviously this study was repeated by researchers in the UK, in Canada, in Germany, and to this day now it is generally recognized that major applications for marijuana is in treating spastic MS patients. But this was sort of a sidelight to my more significant work involving drug development in terms of drugs used in neurology and psychiatry over these years. And in the last perhaps 15 years, I've done much work in terms of investigating the safety of drugs. Obviously, not only cannabis, but drugs used in neurology, such as the antidepressants, antipsychotics, and the therapeutic drugs in general. So that's my background, and I guess that's a good starting point for questions.
I would like to cover the whys of cannabis use with neurological problems. First of all, Doctor, I think we ought to tell the folks that the federal government has a patent, does it not, using cannabis as a neuroprotectant?
Yeah, Julius Axelrod and Hampson and several other folks in the mid-aughts successfully obtained a patent, and the patent is so broad, it really is a joke when you read the patent, but it essentially covers the use of cannabinoids in general with no real specificity as to which ones, but as neuroprotective and antioxidant agents in treating disorders such as Parkinson's disease, multiple sclerosis, Alzheimer's disease, and other, quote, neurodegenerative conditions. And the obvious error in the patent is it essentially would block any independent person without prior approval, essentially via the government, to use almost any of the cannabinoids in medical research. It is really a ploy by the government, which in essence is a way to block independent researchers in this country. But again, it demonstrates the fact that the government has this technique, which is sort of the emperor's new clothes approach. That is, even though there is a vast array of medical science supporting the indications, and they say that in the patent application, organizations like the DEA, the Department of Justice, and the FDA essentially are in denial about any of the medical literature with regard to cannabis. You know, the way the drug development process works, it's not the fact that cannabis can be used in pain syndromes or in spasticity or in nausea of cancer chemotherapy or in post-traumatic stress disorder, etc. The very fact is that we are blocked in the ability to investigate scientifically in the United States.
Could you tell folks about ALS, seizure problems, spinal cord injuries, Parkinson's, Alzheimer's? Those are neurological problems. Does cannabis work for these problems in everybody, in most people? Do we know?
Well, I'm glad that you've given me the next 2 hours so I can go into detail about each of those problems. I'll start with spasticity. There is obviously a full range of data that demonstrates that cannabis has an anti-spasticity effect. Of the maybe 400,000 MS patients in the United States, spasticity is a major problem in perhaps 80% of that group of patients. And there is no doubt that cannabis is effective. Now, there is a small minority of patients that have a syndrome which is not that is not represented primarily with spasticity, but with other physical signs. And those patients may, in fact, not get relief because they don't have the symptom for which cannabis is effective. So there may be a small, maybe 10 to 20% of the patients with MS who will not get benefit, but that's because they don't have significant spasticity. In ALS, the evidence is clear that for certain symptoms associated with the ALS process, and that includes things like excessive secretions or excessive oral secretions, and in terms of appetite issues and in terms of sleep issues, these things that some non-physicians may say are really not important. Well, to an ALS patient, they may be absolutely critical. And cannabis is clearly a benefit in those symptoms. And, although, if you say, well, has there been a clinical trial in ALS? Again, that goes back to the fact that it's very, very difficult to do the clinical trials. So it's mostly observational, but it does support the use in ALS. The second part of that is, in terms of ALS's being a, quote, untreatable disease, remember that the government's patent says that, again, cannabis has antioxidant and neuroprotective properties. And one might suggest then that it might be a reasonable drug to slow the progression of the disease, but that has not been studied in any great depth. In seizure disorders, there may be 30 or 40 different diagnostic types, so I won't go through all of them other than to say that certainly there are many, many patients with seizure disorders who have been shown to either decrease the frequency of their seizures or, in fact, stop them pretty much totally. And again, the mechanism of action of cannabis on the nervous system would be supportive of an anti-seizure effect. But if you're looking for clinical trial data, there isn't a whole lot to hang your hat on. Now, in terms of Parkinson's disease, there are two approaches. Number one is going back to that government patent. Remember, they say, gee, the cannabinoids may be beneficial in Parkinson's disease as far as the neuroprotective aspects of the drugs. The second part of it is, in patients who are initiated on the usual dopaminergic therapies, the drugs like Sinemet or L-Dopa, they wear off over time, and there are many patients who claim that when they use marijuana, it tends to smooth out the on-off effects of their Parkinson's syndrome. Going back to the neuroprotective aspects of cannabis, it may be a drug which slows the progression of this awful neurologic disease, but we don't have definitive data to say one way or another. But it certainly would be a treatment option in patients who are concerned about trying to limit the progression of that disease. So in terms of seizure disorders, Parkinson's disease, motor neuron disease, and MS, there's a multitude of publications which would support, both in animal models and certainly in spasticity in human studies, that the drug would be beneficial.
Before we leave you, Doctor, I wonder if you could just give the folks a couple of examples of people with MS and ALS that you and I both know closely. I'm thinking here of Barbara Douglas and Kathy Jordan, who are both known to you. Could you tell the folks their experiences with cannabis?
Sure. In both patients, what we're dealing with, just to give you the Kathy Jordan story, by all rights, she should have died 20 years ago if you believe the natural course of a disease, which, incidentally, she's been followed by several of the world's important thought leaders in terms of the disease, and she carries with her a letter, or at least a little note supporting her cannabis use by one of the gurus relating to ALS. In MS, now, there have been questions with regard to the whole range of drug therapies because they have a treatment benefit effect, but it really isn't particularly significant when you think in terms of the progression of the disease. I'll give you an example. When we look at the normal MS patient, we can predict in looking at a population that in 10 to 20 years they will be in a wheelchair, and certainly their life expectancy will be decreased by 8 to 10 years on average. Now, when you look at patients, and the patients you mentioned, for example, their survivorship is testimony to the two things. Number one is they certainly aren't progressing more rapidly than the predicted course. And in a case like Kathy Jordan, by all rights, she should have died 10, 15 years ago if you look at the normal path of progression of this disease we call Lou Gehrig's disease, or ALS.
Thank you, Dr. Petro. Again, very much appreciated. I'll talk to you soon.
Righto. Bye-bye.
You are listening to the Time for Hemp Global Broadcasting Network. Please share us with your friends.
You're listening to the Pace Radio Network here at paceradio.net.
Now, the final guest is Mary Lynn Mathre. She is a registered nurse and addiction specialist. She is the president of the American Cannabis Nurses Association, and her job today here is to finish up this conversation explaining why the nursing community, as well as the doctors and other healthcare professionals, are so important to patient care and the care of cannabis itself.
And hello, everyone. We really appreciate Casper Leitch arranging for this show. And what we wanted to do is bring you some scientists and clinicians to talk about medical cannabis. And my job, as I said, we want to bring in the nursing perspective as well, since nurses do spend the most time with patients. In the United States, we tend to be voted year after year as the most trusted profession because we do see patients at their weakest time. And back in 2003, the American Nurses Association passed a resolution in support of cannabis. So I do want all nurses out there to know that, as a whole, our American Nurses Association does support cannabis as medicine, and that is a really, really important place to go to. My practice has been in hospital settings in the early years, first as a Navy nurse, and then later in hospitals as a medical surgical nurse. One of the most stressful jobs we have, and different hospitals do it different ways, but many times you might have a nurse being the medication nurse, or in other areas, the nurses just take care of all of the medications just for the patients they're assigned to. Either way, you're spending your shift making sure the patients get the right medication in the right dose, in the right route of administration at the right time. And it's very stressful. Finding out, sometimes you don't know these patients very well, and you might have 20, you could have 50 patients. In the military, I had quite high numbers of patients at a time, and you're trying to give them all this right medication and hope you don't make a mistake because of what could happen should you make a mistake. Now let's introduce cannabis as a medication to the hospital. I've looked at, and other nurses that I talk with who are familiar with the use of cannabis, we kind of look at it as nurses, as a great tool in nursing care. The medication is safe. We're not going to overdose anyone. We're not going to kill anyone. We're not going to destroy their kidneys or their liver. All of these things that can happen with the wrong medication to a patient. So right away, there's that little safety factor. But as you've heard before from some of the other clinicians, Dr. Abrams, Dr. Hergenrather, there's different routes of administration. Patients don't have to smoke. They can vaporize. One of the guests we've had before, Michelle Aldrich, was able to actually use a vapor pen in California while she was undergoing treatment for lung cancer. And the nursing staff there were very welcoming of that. It had no problems with her, with other patients in the area. No one else was going to get that medication. It was in a dose that she could handle, and provided relief almost immediately. I think the other thing that for nurses, when we're giving medications, a lot of these medications that we do give have the side effects that are difficult to deal with. You treat someone for pain, they end up over-sedated. You might treat someone for something else, and the medication causes them to be extremely nauseated and they're vomiting, or they just lost their appetite because of the medications. Cannabis not only helps with many of the symptoms that patients complain of because of their diseases, but literally helps with a lot of the symptoms of the side effects of the standard medications that they're given. And in that respect, again, trying to use cannabis, the nursing time, I look at it and think how much time I could save if I was giving cannabis to several patients. Again, whatever form is appropriate for the patient, whatever the route, whatever the frequency, but to give them that, and I would say easily 50% of my time. And that's not saying that we get rid of all the other standard medications. There certainly is room for that. But I think the point that I would like to make from a nursing perspective is this should be one that physicians should have the freedom to use their clinical judgment and recommend it possibly as the first choice because it is so safe. If it doesn't work, maybe they need to try other medications and something else. But why start with a powerful drug with potentially harmful side effects when the patient could try something that generally, literally makes them feel better all the time? The other point about cannabis is it's not all about the THC. THC has its therapeutic effects, but it also is the primary psychoactive cannabinoid in the plant. And that's why you've heard them talk about CBD, cannabidiol, non-psychoactive. When taken with a cannabis, when in the cannabis plant with THC, it helps actually lower the high effect. So when we're talking about medical cannabis, we're not talking about super stoner pot to get someone really high. We're talking about delivering medicine, whether it be by a vapor pan, vaporization in some sort of manner, and that's meaning that we're heating the material so that the effective medicine is released and people can inhale it, but it's not hot enough to where it burns, so they're not inhaling smoke. That's a wonderful delivery. But there are salves made for patients, whether it be skin conditions, psoriasis, arthritis, rubbing it onto their joints, using it for skin cancers. The oral, very concentrated oils or tinctures people can take, and they literally dissolve in the mouth, so they get into the bloodstream fairly quickly. All of these things can happen and are happening in places that allow cannabis, but the other states, again, I think the population only thinks of cannabis as smoking marijuana and getting high. One of the big problems we've seen with patients is non-compliance. It happens throughout. It's always a discussion in hospitals. How can we help with compliance? And I think the first thing that any good clinician knows is the way to get compliance with a patient is to make sure that they're included with their plan of care and that they actually agree with the plan of care rather than just being prescribed something and told, here, I want you to take it, and they don't pay attention to how much this is going to cost the patient, how it's going to interfere with their life, if they can remember to take the doses on different times, etc. Or the fact that they just might not like some of the side effects, and the patients quit taking it on their own because it never really helped them that much. Again, cannabis, I think as Jeffrey Hergenrather had said, and others, that they've learned from their patients. Patients often are coming to healthcare professionals saying, this really helped with my spasticity. This really helped with my seizures. I'm having fewer. Whatever it is, they're coming with information. They've discovered this on their own, and they do want to learn more. They want to know, is there a better strain for me to use? Is there a better form for me to take it? This is very important for healthcare professionals to take on. And when we ignore it or just run the other way because of the fact that it remains illegal in the United States and many other countries, that's not serving the patient. It really is up to healthcare professionals to stand up for our patients and advocate for them.
Well, thank you very much, Mary Lynn, for getting in the closing word here on the Medical Roundtable, focused on medical cannabis and the wonderful aspects that this plant has for our healthcare and everyday needs. Al, I also want to thank you for being a great joint host today, and I want to thank our audience for tuning in. Again, I encourage you to try to download this program, share it with your friends, any medical professionals who might benefit from this, send it in their direction. And remember, the next time you hear me, you'll know that it's Time for Hemp.
Look at all that money, yeah, the money that they spent. Take another look now and take some time for hemp. I know cut trees for paper, cause it hurts the environment. Stop deforestation, yeah, it's time for hemp. Oh, an acre of hemp makes 20 barrels of oil. No need for pesticides to poison all our soil. People got no food, they got no clothes, they got no rent. Right now, it's time for hemp.
You're listening to the Pace Radio Network, here at paceradio.net.
The opinions of the individuals during this broadcast are their own, and may not be the opinions of their group or other organizations they may be involved with. All medical advice during our broadcast is not a medical opinion and should be checked with your medical physician.
Enjoy the buzz of legalization with Campbellford Lifestyle Shop. From lights to plant nutrients, books, consumption accessories, and more, we've got all your basics to grow or consume cannabis. Visit our info center or take a look at our piercing services and body jewelry, now available in-store through Campbellford Lifestyle Shop, 17 Bridge Street West, Campbellford.
Limestone City Hydroponics is Kingston, Ontario's hydroponics shop. Take your growing to the next level and create the optimal environment with a tent kit, or maximize your yield with an ebb and flow flood table kit. Either way, Limestone City Hydroponics has more sizes and options to fit your needs. Are you looking for the power of the sun that adapts to your budget? Then look no further, as they have professional grow lighting. They have indoor grow systems that are easy and cost effective, with many options to fit your living space and lifestyle. Cultivate your growing potential. We have everything you need to succeed. And if you can't make it to the store, they offer local delivery to the greater Kingston area. Remember, when you're looking for experts to help you grow, then look no further than the locally owned Limestone City Hydroponics, 105 Sunderland Drive in Kingston, Ontario. Call them at 613-548-0420. We are people advocating cannabis education, here at paceradio.net.